Okay. Today's webinar is brought to you by Scene Health, who is MHPA's silver partner and longtime supporter of MHPA and our health plan members. We thank them for organizing today's presentation, From Fragmentation to Integration, Leveraging Linkage to Care and Public Health Strategies to Bridge the Gaps in Medicaid. And with that, I'm excited to turn things over to our moderator, Sebastian Seeger, CEO of Scene Health. Sebastian.
Thank you so much, Patrick. Thank you for having us. So Scene Health's mission is to help people take their medication correctly and consistently. And we leverage public health interventions to do just that. Public health is known for incredible one-to-one interventions to the patient level that are driven towards an outcome. And many of you may know us for bringing video directly observed therapy to public health departments and then on to Medicaid and Medicaid managed care. But we were born in public health. We're a Hopkins spinout. But when we started working in Medicaid about 5 or 6 years ago, the vision to help people take their medication was challenged by a few barriers. And the fact of the matter is that in order to successfully take medication, a few things have to happen first. You need to see the doctor. You need to get prescribed. You'll need to have tests done, labs, vitals. Of course, you have to pick up your medication, and then you have to understand how to take your medication. So the interesting thing about this is that in public health and in global health, experts have a framework for managing this entire continuum, and they refer to it as linkage to care, which is essentially a framework for resolving the fragmentation that we're going to talk about today, the silos that make the individual patient's journey a challenge. So today we're going to hear from experts in Medicaid and public health on how they help people with serious challenges and deadly conditions get to a positive outcome. And we're using linkage to care as an orienting framework to expose all the gaps that exist along that patient journey. So with that, let's do some introductions. So Rachel, first to you.
All right. Good afternoon, everyone. And Sebastian, thanks so much for having me today. My name is Rachel Bach, and I currently serve as the National Director of Virtual Health Strategy and Clinical Strategic Partnerships on United Healthcare's Community and State team. In this role, my responsibilities include developing and implementing strategies that really focus on leveraging technology to deliver clinical care to our Medicaid and D-SNP members. In addition to leading our virtual care strategy work, I also oversee our clinical strategic partnerships team, who manage a portfolio of digital health solutions. Before joining the UHC Community and State team, I served as the National Director of Strategic Initiatives on the UHC Medicare and Retirement STARS Quality Strategy team. And then prior to joining United, I worked at 2 digital health companies called Cypher Health and Virtual Health in various product management, implementation, and client strategy roles. And then before venturing into the digital health world, I worked as a consultant at the advisory board company. And then my educational background includes an MBA from Northwestern University's Kellogg School of Management. And I have a bachelor's degree in health and societies with a concentration in healthcare markets and finance from the University of Pennsylvania and the Wharton School of Management. And again, thank you so much for having me. Excited for the conversation.
Of course. Thank you so much for joining. All right, on to Michael.
Hi, good afternoon. Thank you again, Sebastian. Really appreciate it and excited to be here with everyone. My name is Michael Sutton. I am the Managing Director for Medicaid Policy with the Blue Cross Blue Shield Association. And really, I have focused on Medicaid and Medicaid managed care for over 10 years. Truly is my passion and something that I love. But you know, healthcare overall has been a focus for the majority of my career. You know, looking forward to the discussion and hoping to get some good questions at the end.
Yes, thank you for joining, Michael. And on to Dr. Burrows.
Happy Wednesday. I am Dr. Christine Burrows. I am an internal medicine and pediatrics dual boarded physician. I have spent the last 20 plus years actually on the front lines providing care in a mostly indigent, underserved, largely Medicaid population, training residents and med students, as well as seeing my own patients. Probably about 5 years ago, really made a sort of a career transition, having seen all the frontline issues to really try and impact change, got some training in the model for improvement. Will be finishing up next week with my master's in population health from Johns Hopkins. And I currently am the vice chair for population health and operations for internal medicine at the University of Cincinnati. And I'm currently co-PI on a grant to build a learning network across the state of Ohio to improve disparities and outcomes specifically for hypertension.
Wonderful. Thank you for joining Dr. Burrows. And now on to Dr. Van Ramshorst. Correct pronunciation, just to clarify, is Dr. V.
Thanks, Sebastian. Good afternoon, everybody. Ryan Van Ramshorst, very fortunate to serve as the Chief Medical Director for Medicaid CHIP Services at the Texas Health and Human Services Commission. Have been in that role for just over 5 years and really, really love the work. I'm a general pediatrician by training, cut my teeth on the south side of San Antonio in the National Health Service Corps, where I was one of the only pediatricians, really wanted to find a way to get more connected to health policy. I've really enjoyed being able to translate clinical experience and apply that to a state policy lens. As you may know, Texas Medicaid is the third largest Medicaid program in the country. We're over 97% plus managed care, currently with 16 Medicaid managed care organizations. Most of our enrollment are low-income children and pregnant women. Really looking forward to the conversation today. Thanks again for the invitation.
Right. So we're really lucky to have experts in public health and in Medicaid, both on the policy side as well as, from different positions, from the managed care side, from the state side. So now, Bob, I'm going to ask you to, Dr. Bollinger, introduce yourself and also give us a quick introduction to linkage to care and all the linkages that have to happen along the patient journey, which is also referred to as the cascade of care.
Thanks, Sebastian, and good afternoon, everybody. I'm Bob Bollinger, professor of internal medicine and infectious diseases at Hopkins. I also have joint appointments in public health and nursing. And I led the team at Hopkins that designed the original SEEN EMOCA solution. And we designed this approach based on our understanding of the public health approach to the addressing the cascade of care. And on the next slide, Sebastian alluded to this a bit. I'm just using as an example diabetes cascade of care to illustrate a couple of points of the way we think about this. If you look at the left, you'll see sort of a typical patient journey illustrated here. You have a population at risk on the far left in the red bar that needs to be screened for diabetes, for example. Not everybody who needs to be screened is effectively screened. Among those who are screened, you have those who next are diagnosed, and then hopefully they get prescribed medication if needed. They then have to possess the medication. They have to go through typically a medication reconciliation process, often called CMR. And then they actually have to take the medicine, as Sebastian said. And then there are a series of outpatient follow-up visits that are necessary, clinical monitoring that's necessary, like A1C checks, blood pressure, creatinine, screening for eye issues, and if you're diabetic. And then that ultimately is ideally leads to a successful outcome, often defined by the metric of an A1C less than 7%. So you can see it's a complex patient journey with multiple steps. And in each one of these steps, there are specific barriers for patients, and it could vary from patient to patient, population to population. I've starred some of those specific steps in the cascade that are often incentivized by the Medicare, Medicaid systems, but not every step that's required is incentivized. And that's, I think, part of what the challenge is as we talk about fragmentation and how to integrate the approach. Ideally, you want to shift to a story that's shown on the right, where you have overcome the barriers at each of these steps, increase access through linkage to care and linkage to support services to overcome the barriers that are causing this drop off in the cascade of care. So you can increase not only how many patients achieve the metrics that are often incentivized, but all the metrics and steps that are necessary to achieve a successful outcome. And so I hope that's a good way to frame the discussion. I look forward to hearing others' opinions about it. So thanks, Sebastian.
Yeah, and Dr. Bollinger, real quick, those gaps between the columns, I mean, these are essentially large portions of population that fall through the crack at that step. Is that right?
Absolutely. Absolutely. And individual patients will have bigger or smaller barriers depending on what their social situation is, behavioral issues, structural issues. So every patient's journey could be a little different, but at a population level, you can display it this way.
Okay, excellent. Well, that's a great introduction. And as you look at that cascade longitudinally, it seems really, really ambitious to expect, just as an example, that seeing a primary care, the beginning of this chain, seeing primary care, for example, is going to, or primary care themselves is going to solve all of these issues. And so as we think, especially about underserved communities, the Medicaid population, the DSNP population, and we look at the cascade of care, first question is going to go to Rachel. So for an individual member, clearly coordination and access becomes the challenge. And you are a leader in virtual care and implementing technology across, some of the hardest to reach populations in the country. So how are you thinking about the barriers that come with implementing these technologies to help people in underserved communities?
Yeah, so when I think about this challenge, I think there's kind of three large barriers that come to mind as I think about what's preventing our members from accessing a lot of these technology-enabled services. The first barrier is the digital divide. So that refers to the gap between those who have access to and skills in using digital technologies and those who don't. If we want our members to use these digitally enabled services, first we have to think about how are they going to access these services. We can have a fantastic member engagement app. We can have an innovative remote patient monitoring program. But if our Medicaid members don't have internet, don't have a device, maybe have both, but don't know how to use them effectively, we're going to have poor engagement with these programs. And these members are not going to benefit from using these types of technology-enabled services. In my opinion, technology is a social determinant of health. And we as an industry need to address this to ensure that our members can benefit from all of the great work we're doing in the digital health space. So right now at UHC, we're taking several steps to address the digital divide. One approach is the establishment of our telehealth hubs or access points. So these hubs are located in private spaces within community-based organizations that feel safe and familiar to our members. They're equipped with high-speed internet and devices that members can use to connect to their virtual care provider or digital health solution. And then in some cases, our hubs even have a clinician or community health worker available on site to assist the member with using the technology and connecting to the provider. So that's helping to bridge some of those gaps on the technology literacy front. Some examples of how this has really come to fruition is recently in our Virginia and North Carolina markets, we've launched a pharmacy telehealth hub program in collaboration with the Rural Pharmacy Network. So members can go to these pharmacies, have the virtual interaction with the provider. The pharmacist can actually perform on site some of the lab work and testing. And then if there's any scripts that are prescribed, those can be filled in kind of that one-stop shop model. So again, if they don't have internet in the home or a device, they can go there and get all that support. In Washington, we're doing something similar, but we're partnering with the FQHC to implement school-based telehealth. So children can go to the school and have access to the digital services that we make available to them. And then in Texas, we're also in the process of launching another telehealth kiosk. So a lot of different flavors with the hubs and something that we're hoping will continue to bridge that digital divide. Outside of the hubs, we're also thinking about deploying tablets and devices to members' homes or to community-based organizations. So in Louisiana today, we have tablets deployed to a number of CBOs within that market. Other things we're thinking about are technology literacy, making sure that we're building telehealth literacy for our members through our marketing and education campaigns. Our goal is to ensure that members can embrace telehealth and technology overall and understand that it's a safe and effective mode of care. And then I think lastly, we're providing funding to select providers to help them address their own challenges with the digital divide. We talk about members and the challenges they have, but our providers are also struggling with the same issues around access to technology or tech literacy. And so as an example, last year, the United Health Foundation committed over $3 million to East Carolina University to expand their telepsychiatry program. So those sorts of grants can go to acquiring technology and training staff on how to use technology. So those are a couple ways we're addressing the digital divide. The second barrier I think about is limitations in reimbursement for technology-enabled services from our Medicaid state regulators. So while in some cases, typically audio-video synchronous visits for telehealth are reimbursed, there's a lot of restrictions state by state on asynchronous modalities of care or audio only. And so again, just because a member lives in a particular state, we're preventing them from benefiting from these types of technology solutions. So I think if we dive a little bit deeper into some of the pitfalls there, I'm a big fan of asynchronous. I know that's something that SEEN uses within their platform. But when we're looking at states that are not reimbursing for it, essentially what that's doing is that we can't meet our members where they are on their own time because we're not able to use asynchronous. We can't use asynchronous to provide a safe and private environment for some of our members that might not be able to outwardly discuss their health concerns in their household. Even if we think about stigmatized conditions, some of our members find it easier to write down kind of some of their concerns than talk to a live person. And then also for asynchronous, that can be used to help address the digital divide. So these reimbursement restrictions are really limiting all the technology benefits that our members can have. And then also on the audio only side, in some cases, if a member doesn't have a smartphone, doesn't have internet, the only thing they can do is talk to a provider over the phone. And if they can't go in person, then they have no access to care. So to overcome some of those barriers, we're actively advocating to state and federal regulators to expand reimbursement. We partner with the American Telemedicine Association, and last week we actually had a huge win. So the House Ways and Means Committee passed the Preserving Telehealth Hospital and Ambulance Act. So that extends all the telehealth flexibilities for the next 2 years for Medicare, but we see that having implications for our Medicaid plans. They typically kind of follow suit on what the federal government is doing. And then the last barrier I'll quickly talk about is provider adoption and their overall familiarity and confidence in technology-enabled clinical services. It's critical for us to be training our medical professionals on how to use virtual modality and also just make sure they understand the value of it. I think, as I mentioned, telemedicine is a safe and effective mode of care. It is medicine. And so really to tackle that barrier, we've developed telehealth fact sheets, implementation guides, and resources for our providers so they can understand how to implement them themselves and also just understand the value so that they can encourage their patients to use the solutions that we make available. So certainly a lot of things we're doing at United Healthcare to ensure our members have access to tech-enabled services, bridging the digital divide, advocating for policy changes, and then really educating our members and providers on the benefits of tech-enabled services.
Rachel, that was great. And one of the things you said was super interesting in particular when you were talking about asynchronous, because you mentioned that a lot of asynchronous technologies aren't reimbursed, which is clearly the case. A lot of times the concerns around asynchronous relate to the fidelity of the interaction, but also to privacy. So normally you get pushback on the privacy side. So I was actually quite interested to hear you bring up privacy as an advantage of asynchronous, and I don't think that that's talked about. And I do know that in a lot of cases, the stigma associated with the condition makes it such that when you have the ability to, like, on your own in private, enter something or, via a device on your time, that can be life-saving in a lot of cases, but it can also just be destigmatizing. You also brought up, though, enabling providers with regards to technology. So I want to actually ask Dr. Burrows about the provider side of this. And Dr. Burrows, you're sitting both.
I already was like, I need to make a comment on that because I was thrilled you brought it up. So we were trying to teach and do interactive learning on best practices for hypertension management with 3 federally qualified health clinics. And it turned out we had all these problems. They did not have in the health department clinics Wi-Fi. And it blew my mind that we would have, but when you think about it, practices that serve Medicaid, given the reimbursement, given the challenges to get people in primary care, we literally were having barriers because they did not have Wi-Fi available in these clinics that serve Medicaid.
Right. I mean, also let's not forget that 10 years ago, 12 years ago, health systems were adopting electronic medical record systems. And from all our public health customers now, we're getting integration questions because they are just, some of them just beginning to adopt EMRs now. So there is an absolute technology divide when it comes to community health centers, FQHCs, public health departments too. And I know it's a major push for MCOs to work with community-based organizations. So I think that's a challenge. But Dr. Burrows, when it comes to the provider side of managing this cascade of care, my understanding is there are not more physicians, there are not more nurses coming. We're facing a shortage. Can we actually ask providers to do more?
Yeah. When you think about it, patients spend the majority of their life, majority of their time in their life, not in the doctor's office. If you're seen for a 15, 20-minute visit every 3 months, an hour of FaceTime a year for a condition that they are managing, like diabetes or hypertension, 24/7. And so how do we actually effectively get education on nutrition, education on sort of exercise, education on their medicines and their condition, and understand what the specific barriers are for an individual patient? So there are components of trust. And in addition, though, how do you help a patient to be comfortable enough to share what their barriers are that are limiting their health and well-being with their managing their chronic conditions? And so how do we figure out as a team, how to do that? And we have, many things. So I'll give you an example. In hypertension, you'll have a patient that comes in one day, their blood pressure is 200/100. You give them some directions. They're supposed to show up a week later. No one follows up. And it's, they were supposed to be there a week later. A year later, they stub their toe and they come in because of their stubbed toe and their blood pressure is still 200/100. And the only reason they came in was the stubbed toe. How do we have wraparound services that, are catching these members? And the other example I'll give you is sometimes with the different plans having different insurances or lapse of insurance, all the barriers that these patients, limit their access to care. I've oftentimes thought of the other benefit of potentially using telehealth services to better integrate CBOs in the healthcare office. Could there be a kiosk in a doctor's waiting room where we identified that, you are having food insecurity or you didn't get your paperwork to fill out and your Medicaid's going to lapse, that we could make you a virtual visit with Jobs and Family Services or what other, because that oftentimes you might say you need to do X, Y, and Z, but there are many barriers and transportation for them to get there, or they call the agencies and they have a wait forever. They, don't follow through. How can we connect better and be part of sort of building a safety net around identifying the patient's barriers?
It sounds like a lot from the provider side, just because, like as Dr. Bollinger pointed out, if you're not going to work through the cascade of care, you're not getting to the outcome. And then as a provider, as a physician, as a nurse, as a social worker, you are trying to address the problem that's immediately in front of you. And it just makes for a very challenging situation. So with that, thank you, Dr. Burrows.
Yeah. And I will say, when you think about the patient's journey, I think you're spot on, because the patient's journey involves so much more than their time in the doctor's office. It's actually the time between when they leave the doctor's office and the next time that they come that we need to know they're being connected to what they need.
Exactly. Well said. So, Michael, based on what Dr. Burrows just said now, and then if you think about Dr. Bollinger's two charts, the one on the right side, at least from our perspective, it pointed out that it's not just linkages to care, it's linkages to social support services. So in terms of, from the public policy perspective, a lot of these little linkages, so a lot of that cascade, the reasons for dropping from one to, the drop off from one to the next has to do with barriers related to social determinants of health or non-medical drivers of health. And we've got a fragmented system. So from a public policy perspective, do you have thoughts on designing a system that makes the patient and their outcome like the singular focus and the center of the system?
Absolutely. And, I just nodding and going along, as I'm hearing everyone, so I'm like, yes, this totally makes sense. I think, first and foremost, we really have to design programs to meet individuals where they are, right? Like that's really the big key. Creating no wrong door policies where regardless of how an individual becomes connected to the healthcare system, they're linked to all the resources they may need in addition to that comprehensive care. So, as an example, I like to use the NC Care 360 program that's part of the Healthy Opportunities Initiative in North Carolina. It's a statewide coordinated care network that electronically connects those with identified health-related social needs with community resources, and then allows for that feedback loop on the outcomes of that connection. So it's a shared technology platform that enables the healthcare and human service providers to send and receive secure electronic referrals, communicate in real time, and then securely share those client information that they can then track the outcomes as a collective. There's also a component of the community engagement team really working with the CBOs, the social service agencies, the health systems, et cetera, to build that statewide coordinated care network. So it's truly bringing together all resources across the healthcare spectrum to really fill the gaps in for people. And I think when we think about these kind of innovative approaches, there's really sort of two key takeaways, right? So first, Dr. Burrows alluded to it, it's bringing dignity back into healthcare, right? And allowing a person to take ownership of that healthcare journey in the way that makes sense for them. And then second, when you have this sort of standardized, approach, you do start collecting really comprehensive data that can point to successful interventions, which then in turn supports, further investment in areas that otherwise, may not receive adequate assistance. So, for example, extra dollars to community-based organizations to enhance their infrastructure, right? Or that training, or, to bolster staffing. So I think really looking at the all hands on deck approach and really thinking about how that can help to improve health outcomes for people.
Yeah, I think I like the all hands on deck comment combined with the first thing you said, which is you have to meet someone where they are. And the fact of the matter is you just don't know, right? Until you do know, and then you need all the options available because that specific person's barrier may be something that, you wouldn't have noticed from, let's say, if you're at the MCO level, claims, for example.
Yeah. The other thing, Sebastian, I'd say really quickly is that it's about asking, not telling, right? And that's so important because what we may think a person needs is not what they need or what they want in their situation and in their life right now. So I think, from a healthcare perspective, it's super important for us to remember that as we engage.
Right. Absolutely. And you, in asking open questions, you just don't know that specific person's situation, right? And it could be a variety of things. We have a significant part of our population that has complexity in their life. And the fact of the matter is, even if you don't have complexity in your life, managing our healthcare system, managing health insurance, it's complicated. It's hard. So I totally agree. All right, going to Dr. V, and from the state of Texas perspective, tell us about some partnerships that you've built. I know you've got quite a few that really do address the cascade of care. I mean, we've talked in the past about examples of programs in Texas for people with hepatitis C, maternal health examples. Perhaps talk about some of the partnerships you've built which address the topics that we're talking about today.
Yeah, happy to do so. I think one of the many silver linings of the pandemic was really solidifying the relationship that we, the Medicaid agency, have with our state public health agency known as the Texas Department of State Health Services. And we've really been able to follow their lead as the state public health agency in helping to take their ideas and their priorities and make sure that we're using Medicaid to help address those issues in the individuals that we serve. I think hepatitis C is a really good example where our public health partners have been working on this issue for some time. There were some challenges on the Medicaid side, but we have since executed a contract with AbbVie, the drug manufacturer, where we now have a subscription model for accessing one of the direct acting antiviral medications to cure hepatitis C. The challenge, Sebastian, and to your question, is that cascade of care and thinking of all of the individuals that are unknown to us because they haven't been tested. They haven't been able to interact with the healthcare system. The healthcare system hasn't met them where they are. And so we've been working very hard with AbbVie to get the word out to our providers that these medications are now available without a prior authorization, figuring out how to work with community-based organizations so they can help work with the people they serve to know that these medications are available in the Medicaid program. And so still lots of work to do, but I think we've set ourselves on a nice path, and that contract with AbbVie has been really fruitful this far. And the second thing that I'll call out is congenital syphilis. We know that many southern states are struggling with this, Texas being one of them. Again, taking the lead from our public health partners, we have been able to make sure that the medical directors of all of our 16 Medicaid managed care organizations are in the room to talk about the strategy to address this. You know, one of the things that we have done is connected those medical directors, even though they might work for a health plan that operates statewide or in many areas, to work with local public health agencies to walk through cases of individuals and families impacted by congenital syphilis to make sure that those connections are happening. And so, again, it's been really neat to see how we've been able to connect public health directly to the good work of the Medicaid managed care organizations in Texas to address these very complex issues where non-medical drivers of health are really, really contributing. And so we look forward to continuing that work in Texas.
And thanks for silver linings are always welcome. And Dr. Bollinger, jump in on this one. So here's I think a great success story. If you look at, there's a paper on the cascade of care from 2011 for HIV. I think Hep C's followed a similar pathway. The rate of viral suppression was at about 18% in this paper. And, you know, this was right as the ART medications were coming out. And if you look now at the HIV, the most recent HIV data, the rate of suppression is over 60%, which one would argue is maybe not enough, but man, that's 5 times what it was just over a decade ago. Dr. Bollinger, Dr. Van Ramhorst, comments on how we ended up with, is that a success story? Is it not?
Well, it's clearly a success because the number of people dying of AIDS, of course, is going down. The complications are going down. That's really what matters, right? And it's not just a number of viral suppressions. And but I think I don't know we can attribute the success of that to one single intervention, right? I think it's a combination, as we've talked about, a more integrated rather than fragmented approach to addressing. And I think. Rachel started this conversation about addressing patients where they are, right? Using an asynchronous approach, for example, which gets people engaged where they are, whoever they are. And it not only is a benefit in some of the things that she mentioned, such as addressing stigma and so forth, but I think in general, it also, and I think Dr. Burrows talked about this, when you meet people where they are and you make where they are part of the health system, rather than just an interaction, you make the workplace, the household, their community part of the health system by meeting them where they are. You also learn a lot more about what their real barriers and issues are. So if I'm in the clinic and seeing patients, for 15 minutes once every few months, and I'm asking questions about what their challenges are, I'm getting an answer. But I could get a very, very different answer if I'm engaging them where they are, right? Through some of these tools that Rachel talked about and others have talked about. And I think that's valuable because it allows us to direct them to the services they actually need. We don't always get everything we need. We don't learn everything we need to know in a single office visit or even a single telemedicine visit, but having asynchronous ability for people to share issues and concerns with us at the time that's convenient and place convenient for them. I think it's going to really strengthen our ability to optimize their linkage to these support services. So I think that's true for HIV, that's true for hepatitis C, it's true for hypertension and diabetes.
So to that point, to enabling this broad infrastructure, maybe back to Rachel, you did touch on a couple policy developments that are happening. What's on your wish list of policy changes that enable a more accessible technology infrastructure so that a lot of these modalities can become part of care, and so that the locus of care can also include where the patient is?
Yeah, absolutely. So I think, just to reiterate, reimbursement for all virtual health modalities would certainly expand access. I think the other thing is, reducing some of the limitations on the types of clinical services that can be delivered virtually. There's been a lot of talk around being able to prescribe medications to treat OUD and SUD conditions via medication-assisted therapy and requiring an in-person visit for that. So continuing kind of with the PHE flexibilities to allow for virtual-only providers to get those life-saving medications in the hands of our members is important. There's policy restrictions on the types of clinicians that can provide virtual care services. There's also limitations on where a member or a provider can be when delivering that clinical care. So in some states, a member can't be in an FQHC and be talking to a provider in another location. So those, again, the place of service codes, I think, need to be updated to reflect where our members are and what they have access to. And then kind of broader beyond just telehealth, I think some policy changes. So the Affordable Connectivity Program just ended in April, and that was providing grant money to members to be able to purchase broadband internet. I'd love to see that program funded again so that we can continue to build the digital divide. I also think just changes in terms of building out our infrastructure around broadband towers. They're very expensive, as I've learned, and being able to bring technology to rural areas or those that don't have it. And we certainly need public funding to be able to do that. So those are a couple things on my wish list.
You, as you're speaking, this reminds me of Dr. Bollinger talking about his I'm going to just say it, talking about challenges in rural Uganda back in 2010. I mean, it is incredible that some of the same challenges you'll find in the developing world we're going to find in rural, disconnected regions of the United States. So I think we really do have a lot to learn from the public health system, and including the global health initiatives that we actually export right through a lot of NIH funding to cure and solve problems abroad. Michael, policy is your expertise as well. From the MCO side, aside from technology, recommendations from your side?
Yeah, so I think there's three really important ways that policy can impact, healthcare integration, really avoiding that fragmentation. And I alluded to it earlier, but first and foremost, it's more standardized data, right, across the states to track outcomes for interventions. And we want that data to be apples to apples, right, because the states are very all over the place in what they collect and how they utilize it. From a managed care perspective, when we have that information, it's how we are able to bend that cost curve and devote resources to the best practices that come out of there. I think also, from that perspective, understanding what data states already have collected and how it's being used at the state, local, and federal level to influence those policy changes. Because I think there's a lot of unknowns, and there may be opportunities to better leverage the data we already have or that exists, rather than collecting completely new data elements to sort of recreate the wheel. I think second, if we go back sort of to that person-centered care conversation we had earlier, we know when patients have health-related social needs met, are likely to engage on a deeper level in their healthcare needs, which overall leads to better outcomes. So allowing for these health-related social needs solutions to be included in the numerator of the medical loss ratio calculation would really allow managed care to be more aggressive with innovative investments that address filling the gaps in care and again, minimizing that fragmentation. In lieu of services is another tool that states can use to address gaps in care. They can be included in the numerator of the medical loss ratio, but states really, again, vary significantly in how they utilize in lieu of services. So that's another opportunity. It really opens up a lot of room for states to be creative in how they use the authority to address SDOH. So would love to see more of that happen. And then finally, helping managed care close the gap to access to care. And Rachel sort of touched on this too, but, while managed care can utilize telehealth services, those services don't count towards network adequacy and the newly established appointment wait time standards if there's not a brick and mortar option with the providers that the beneficiaries would see virtually. So it makes it really challenging to meet those standards, as well as impacting individuals who may not have the option, to visit providers in person, especially when you're monitoring those chronic conditions. And, again, we've talked about it, the workforce shortage issue, right? Like, we're trying to get as many people care as possible with smaller and smaller buckets of providers. So I do think that if we were to start addressing some of these really critical pieces, in the whole healthcare conversation, that will start building that bridge, certainly in Medicaid and in healthcare overall.
I just wanted to add to that. You talked about the data access and thinking of the silos of what the MCOs know about a patient versus what the provider's office knows, and how there's duplication of services. There may be care coordination happening and community health workers trying to address social needs at the doctor's office versus some outreach doing similar things at the MCO, and yet the left and the right hand, have not had the opportunity. And one of the things with our grant in Ohio we're looking to do is to actually get the MCOs and the practices more aligned in terms of actually interacting with one another, right? Having the access to data, how do we do this, and how do we actually become efficient? And I think, to your point, what North Carolina has done is stunning, because you want to have also data so you can measure outcomes, right? Is this intervention one that's working? And being able to track that and not duplicate things that are maybe not even working, right? So data and collaboration in those silos is going to be critical.
I don't know who wants to take this one, but Michael, you talked about the MLR and the fact that some of these solving for certain social determinants doesn't necessarily fit into that. I'm hoping that you're able to, in a nutshell, explain that to anybody in the audience who might not get that subtlety. I think it's the same, in a way, it's a similar point to what Rachel was making about reimbursement, that okay, if you're going to get to an outcome, Dr. Bollinger put it up on the screen, there are social drivers here that have to be resolved, but clearly there is, in addition to those barriers, there is a payment or like an incentive problem here for managed care. Can you boil it? I know it's
I mean, MLR is not an easy topic, not a fun subject, but Medicaid dollars have to be used for medical services. And so when you're introducing non-medical services like those wraparound SDOH, elements, housing, food, transportation, outside of what's in the medical benefit, it's not paid for, essentially. So as of right now, when plans do implement those programs to improve those outcomes, it's all out of their bottom dollar. It's all out of their administrative dollars. And again, that can stifle or have a chilling effect on what plans really want to do above and beyond what they're currently doing, and be able to reach more populations. So it can be quite the challenge to make sure that you're being good stewards of dollars, and both the taxpayer dollars and the dollars that you're receiving for your resources.
Yeah, that feels like a massive overlay barrier for everything. Okay, so maybe on to, and thank you for that. You kept it short and sweet, and I think it is a major challenge. Dr. Van Ramhorst, the coordination of care that between the health plan, the provider, and then Dr. Burrows, jump in too. So that's not that simple. A provider has many health plans, and health plans have very many providers. How about from your seat at state Medicaid, what you're doing to address those challenges?
Yeah, so I still maintain a part-time volunteer clinical practice, and I can tell you that I am much more aware of the service coordination that is available from the MCOs. And what I found especially when I see kids with medical complexity, is I will make sure that I am outreaching to their service coordinator, who is usually very, very excited to take my phone call, and then will tell me how many times they have called my office trying to talk to me. But because we're so siloed, that communication is not happening. And so I think service coordination is certainly one of the best things about the managed care model, but figuring out how to bridge this divide, there's just no easy way to do that. I know that there's electronic health records that MCOs are able to access, and they have NMDOH built into them, but still it's not the same as having that one-on-one phone call with the service coordinator to make sure that family is receiving services. A couple other things that I wanted to bring up, going back to Michael bringing up the medical loss ratio, and I will say it is dangerous when you get a general pediatrician talking about a medical loss ratio. But one of the ways that Texas has sought to address this issue is we allow our MCOs to count costs associated with non-medical drivers as quality improvement costs, which is different than as an administrative cost. It's not to say that the money is in the capitation rate, but it doesn't negatively impact their medical loss ratio to help remove that disincentive, if you will. And really, it's our health plans that help to identify this. They're actually now in year 5 of a learning collaborative effort that's supported by Robert Wood Johnson, the Episcopal Health Foundation, as well as our Health Plan Association. And so we have every single one of our plans that are part of that work. We have provider groups, we have advocacy organizations representing members, all coming to the table about what is the best way to address this. Michael brought up the North Carolina model. They're really viewed as a leader in many ways. It's not the approach that Texas has taken. It's really been our managed care organizations that have banded together, that are using closed loop referral platforms. And we as an agency issued a non-medical driver of health action plan for the first time in the history of our agency last February. And not surprisingly, identified housing, food, and transportation as our top 3 issues, trying to give direction to our MCOs about where we wanted them to go first. And as a sub bullet of that is really having them focus on data. The other thing that was mentioned is the payment aspect here, and kind of putting on my provider hat. We know that providers have been doing this work for a long time, and there's not necessarily an add-on code that you can add to your well child visit to say you did an NMDOH screening. We know that a lot of our MCOs are using alternative payment models to help support providers in doing this work. A lot of the best examples are an MCO working with FQHCs in their network. I know FQHCs have been brought up a number of times in this call. And so it's really been neat where the state agency, the Medicaid regulator, has really just been able to watch this work happen. We've given direction. We've tried to remove barriers, but it's really the MCOs that are moving the needle in Texas on this issue. It's been really great to be a part of that.
Awesome. Dr. Burrows, comments on payer-provider relationships?
Well, I think you hit one feature, which is for the provider, there's so many different MCOs that you might have to collaborate with, right? And even some of the more simple things like just care coordination for a patient, providers don't know the first thing about how I would connect a patient to their services or a care coordinator, at their MCO. So, there's opportunities, and I'm, how do a system is designed to get the outcome it gets, right? How do we design a system where that brings the providers to the table or the MCOs and providers to the table to be swimming together towards these outcomes? A lot of the value-based care, while I am going from fee for service, where you're really just driven by volume and not necessarily the outcomes, moving towards value-based care and metrics is great. However, I'll caveat it, which is the metrics fall on primary care that oftentimes have the least resources. So, and they're set up as additional payment to the providers if you have your A1C controlled, if you have your hypertension controlled. And when I look at practices in our system, our practice that serves largely inner city patients with complex medical conditions and lots of social drivers, we have learning collaboratives, we have outreach, we have tons of work we do to get to 63% hypertension control. But our neighboring practice in our health system that is in a very wealthy neighborhood is at 82%, and they do nothing in terms of any quality. So they get paid more money. We actually need the more money to try and do the work that we're doing to even get it from 55 to 63%. So the approach of paying for the value, I think, is there's still a disconnect when it comes to these social drivers and helping providers have support instead of feeling penalized to care for vulnerable populations.
Yeah, I mean, Dr. Bollinger put up the asterisks on that chart. Those parts of the cascade, there is an incentive, like so stars or HEDIS metrics are often geared towards getting to the provider, getting labs done, having certain visits, checks, etc. And then some are geared towards the outcome, like A1C control. It's just that sometimes, like when I hear gap closure, I hear something different than linkage to care, right? Like there are companies or there are initiatives that are singularly focused on one of these, and it feels like an incentive that
we're chasing dollars. I feel like
Yeah.
they're chasing the metric of the day that gets them the value-based dollars, as opposed to building a system of linkage to care for all of the quality metrics.
We're on the same page there. All right, we do have questions that have come up in the chat. I'm going to read one out. How does patient, and raise your hand if you're interested in taking it. How does patient trust play a role? It seems like disadvantaged communities might be less trustful of health systems that exist, sometimes for good reason. See divergent prenatal outcomes for Black women in America, and generally have a different relationship to health and wellness. How do we bridge trust?
I'm gonna go ahead and jump in right away in that it's a passion of mine, trust, because I have found that a lot of times people will see a patient that maybe is a high utilizer or uncontrolled, and they think that just equals refer to care coordination, and miss the point that there's a relationship-based component, especially in populations that have been disproportionately impacted by racism and structural racism. And so what I have experienced is patients will share things with me and will be communicating to me why they maybe don't want to take a medicine, because they feel like there's trust. And so there's got to be this ability to build trust. And how do you do that? It's relationship one-on-one. It can't be mass produced, right? So we want to address things in the population, but at the end of the day, you're still going to need a one-on-one sort of interaction that gets at what is the cause that's driving it. So I think that personalized component still needs to be considered in how you do it, which is why the care coordinator sitting in an office just calling you, is really hard. Now, maybe if we are putting our resources together and a provider practice is referring in the MCOs and we're collaborating and there's trust. But again, there's a lot there. If I don't trust the MCO is going to take good care of my patient, and how do I know? Am I going to refer to them just because the resource exists? So you have a great question, and that trust is critical.
And I think, Rachel, you're unmuted. Or you want to take it?
Yeah, so I think I responded in the chat as well. But if I think about from a virtual health technology lens, how we can build trust, I think one of the great things about these tech-enabled services and virtual care is that we're better able to match members with providers that look like them, that have similar lived experiences to them. If I'm a member living in a community and I'm the only person that looks like me, and all the docs don't look like me, or clinicians, I think that's going to be challenging in building trust. If I can sign on and find a provider that has a similar experience to me, looks like me, I think that's an avenue to continue to build trust and just building more access and health equity to a more diverse set of providers. And then I think the other thing for patient populations that are fearful of physically going into an institution, a health system, being able to have a virtual visit from their home just creates more comfort. And I think that's also an avenue to build trust. So I think that's the lever for virtual and how that can help with the trust issue.
Excellent. We've got a really good one here. So with prescription drug costs such a huge component of healthcare costs, and medication adherence being problematic for LEP and low health literate individuals, what are you doing to address this issue as part of social drivers? I've got a one-sentence answer to that, which I'm not going to give. But
I can give that one sentence answer. So one of the things I'm piloting with Ohio Medicaid is Scene Health. And in particular, I'm doing it because this is not prompted, but one of the things I think that is critical is we have to be sure that the patients, one, are able to get the medicine, that they understand it, and they want to, and that the barriers, and sometimes the barriers are, they're still afraid to take the medicine, or their friend told them they're going to get this side effect, right? And so it's not even just as simple as looking at what's the rate of fill in the pharmacy. It's actually that next step of someone addressing what your concerns are and doing what I think is a great opportunity, this directly observed therapy, to really see, are they taking it? What's the outcome? What's their blood pressure? And organically in their life, understanding what their barriers are. So, again, somehow there's got to be some way to address both fill rates, but also actual adherence. You have
And I
those
felt-
patients who come in with 10 bags of meds that they've been carrying for a year and they haven't taken any of them.
I selfishly love the answer. Mine would have actually been exactly what we're talking about today, which is managing upstream of that last mile, which is med adherence. It's everything we're talking about, which is enabling technology infrastructure, policy changes, getting people linked into care, managing social determinants of health. Those I think are actually all relevant to medication adherence, because you're not taking your medication if you're not prescribed, seeing a doctor, et cetera. All right, I think we have time for one last question. So, this is interesting. So we did talk about MLR. I think I'll push this one over to Rachel or Dr. Van Ramshorst. Michael, jump into this. Is actually a policy question that you may have hit. So let's do rapid fire, and I'll end with a question that you won't get to answer. We'll do it another time. But so this is about getting administrative fees into the MLR. I think it was touched on before. Rachel, I know you've had some success there. Michael, jump in.
Yeah, Rachel, go right ahead if you want. That's fine.
I don't actually know if I have the answer. I think we're definitely doing it, but that's a different
May also
team.
be a
But
state
we
by-
definitely have had success in getting administrative costs into our MLR successfully for majority of our health plans. Yes.
And I think that that's one of the challenges, though, as you'll see with Medicaid, right? There's no sort of one size fits all. It's all across the board, and so it does get really challenging when you've got a state that's being really innovative and forward facing, and is doing exactly what you're describing, Rachel, and then others that, and again with in lieu of services too, that sort of drag their feet and are just not as excited about change and excited about really trying to shift the paradigm of how Medicaid is, how the program's operated. So I think that we want to be good partners with our states. We know that they're so important, but there are some barriers to that at times.
And timely as well. So we are coming to the end of the hour here, but it's just so incredible that at the end of the day, the complexity of the payment models is really a huge barrier. I do see a comment. I just wanted to read a comment out that I think is really great in the chat. And it was a response to, how does patient trust play a role? So I'll just read you this one. One way we've seen trust established is through the deployment of peer-to-peer models. Really changes the patient-provider relationship dynamic. Yes, of course. I think the one-to-one nature, one-to-one is such a great recipe for success in general. So, any last comments from anybody before we turn it back over to Patrick? Well, if not, I'll leave you with this question then. Here's the question for the next one, which is, let's assume all these social determinant non-medical drivers of care do become standard of care, and let's say in an ideal world in the MLR, reimbursable, et cetera. So is the role of the MCO becoming very similar to the role of the public health department? I think I would love to dive into that one, because this is what public health departments do. They drive patients from step to step to outcome. They're strapped for funding. They're outside of all our payment mechanisms. And, you know, they are very understaffed. So the support that MCOs are giving to our public health system is incredible. And so I'd like to thank all of you for all the work you do. I think everybody working in Medicaid, whether it's on the policy side, at the state level, at the MCO level, hearts are in the right place. Providers serving underserved communities, hearts are really in the right place. So thank you for joining us today, and thanks for all the great work you're doing to serve communities that really need a lot of help. Patrick, over to you. Thanks so much for having all of us.
No, it's for me to thank you all. I think this is one of the best presentations we have. That's clearly evident by the audience participation and these great questions. So again, you guys are rock stars. This was a wonderful presentation. Thank you. A reminder to our audience, we will have this presentation on our YouTube page in the coming days. And if you'd like to connect with SEEN, you have more questions, I'm sure they'd be happy to reach out to you. Email MHPA or connect with SEEN. We're happy to help you. And then lastly, don't forget to attend MHPA 24, September 11th to 13th. You'll see SEEN there and many of our other MCO members. So hope to see you there. And with that, thank you all so much and have a great afternoon.
Thanks, everyone.
Thanks. Bye, y'all.